In episode 18, we talked about the antibodies seen in myasthenia gravis, but we really didn't go into the details of how a patient with myasthenia should be managed. So if you have a patient who comes in with weakness and you find one of those antibodies, what do you do? Should everyone get a chest CT scan? Should patients without a thymoma go for thymectomy? How do you treat acute flares of myasthenia? And how do you manage these patients in the long run? Welcome back to Brainwaves. I'm Jim Siegler. Today, managing myasthenia gravis. From steroids to surgery, we'll cover it all. So you've made the diagnosis. A positive acetylcholine receptor antibody. Whoopity-doo. What next? In managing myasthenia, I think there are four main approaches to treatment. Symptomatic relief with pyridostigmine, immunosuppression with corticosteroids. Alternatively, there are steroid-sparing agents like azathioprine, and lastly, surgery, meaning thymectomy. We'll get to that last because it's interesting, and I want y'all to hear about all the other things I have to say before we get there. Let's start by addressing symptomatic treatment. Our go-to drug, one most patients tolerate, is the cholinesterase inhibitor pyridostigmine. Because of the major cholinergic side effects, nausea, diarrhea, bradycardia, etc., most providers start at a low dose, 30 mg 3 times a day or so, and they increase as tolerated to 60 or 90 mg 4 to 6 times daily. Some of the best advice I've gotten in managing these patients is to think of when patients get their symptoms. Usually, myasthenic patients complain of more difficulties with double vision or weakness later in the day, so maybe you'll want to backload those dosing intervals, either by dosing the pyridostigmine in the afternoon or the evening, or using higher doses as the day goes on. The side effects, like I mentioned, can be dose limiting. Most importantly, I think you have to watch out for bradycardia. But symptomatically, patients will complain of more GI distress from the pyridostigmine, which produces its effects at both nicotinic and muscarinic acetylcholine receptors, and these patients may benefit from a muscarinic-specific antagonist, something like glycopyrrolate, usually 1 mg twice or 3 times a day, or hyoscyamine, 0.125 mg a few times a day. I like to imagine that treating a patient with pyridostigmine is like attacking the problem with a BB gun. It's not exactly a toy, it works, don't get me wrong, but it takes a lot of time to make a little bit of damage. A longer-acting formulation of pyridostigmine, Mestinon TS, 180 mg, is also available. It's like a BB gun that automatically reloads for you. You can use the extended-release pyridostigmine at bedtime in patients with persistent, severe weakness upon waking. Most patients, like I said earlier, however, do better after a night's sleep, and they won't need the long-acting version before they go to bed. But if patients wake up with significant symptoms, you might consider the longer-acting formulation. Another nice thing about pyridostigmine is that for your patients who can't tolerate oral agents, there's an IV or IM equivalent you can give, which is about 1/30 the oral dose. So 2 mg IV for a typical 60 mg oral dose. But like oral pyridostigmine, it provides limited, temporary improvement in symptoms. Since we're using the analogy of pyridostigmine being like a BB gun, you can imagine your solution might backfire on you. I didn't actually intend for that one to be a pun. But anyway, too much of a good thing can sometimes be a bad thing. One consequence of taking too much of a cholinesterase inhibitor, besides the nasty GI side effects, the sludge symptoms, and the bradycardia, is that it can paradoxically cause more weakness. And this can be tough to distinguish from a myasthenic flare. When weakness occurs from excess pyridostigmine in these patients, it's called a cholinergic crisis, not a myasthenic crisis. I don't think there's a great way to distinguish a cholinergic crisis from a myasthenic flare using any laboratory test. You've got to rely on your clinical history and exam skills. Someone taking over 1,000 mg of pyridostigmine a day, or someone who's taking much more than they'd previously been taking, would be the kind of person I'd worry about having a cholinergic crisis. And on history, you might expect more of a muscarinic toxidrome in addition to the weakness, so the patient may have more salivation, lacrimation, GI distress, and so on. Moving back to the treatment of myasthenia, if you want to attack the problem with something stronger than a BB gun, you tank your patient up with steroids. This would be like using a shotgun. And like a shotgun, which sprays a bunch of tiny metal pellets in all directions, steroids impact the human body in all kinds of ways, good and bad. Specifically, in myasthenia, corticosteroids act by suppressing T and B cell function, which are implicated in antibody formation and acetylcholine receptor degradation. But steroids can also cause osteoporosis, cataracts, insulin resistance, and hyperglycemia. They can negatively impact sleep, and so on. And when you start steroids in a patient with myasthenia, most providers do this pretty slowly. You don't want to up-titrate an oral course of prednisone too rapidly because it can cause transient but significant worsening of symptoms in 30 to 50% of patients. And this deterioration usually occurs within the first 5 to 10 days of steroid use. It's kind of unclear why this happens, but it's a well-recognized phenomenon. That being said, we use steroids because they're effective, and roughly half of patients will experience significant improvement in their symptoms on oral steroids, and about a third of patients will experience complete remission of symptoms. For inpatients who are being monitored, many providers will start by using 1 mg per kilogram prednisone daily, generally about 60 mg or so. And in outpatients, you might start a patient on 10 to 30 mg a day of prednisone and increase by 5 mg per day every week until you get to about 60 mg daily. Steroids begin to take effect after 2 to 3 weeks and are maximally effective at 5 or 6 months, unlike pyridostigmine, the BB gun, which works within 10 or 15 minutes, and it's maximally effective at about 2 hours, but it wears off more quickly than steroids. Eventually, however, you'll want to get your patient off the corticosteroids or get them down to much lower doses, like 5 or 10 milligrams of prednisone a day, because of the side effects. And you'll just have to see how the patient responds to a very slow taper once symptoms are under better control. There's not much advice I can give you on this, and this podcast is not meant for clinical decision making. And while steroids are great, they're like using a shotgun, right? High impact, pretty effective, gets the job done. The side effects are intolerable in the long term. Osteoporosis, diabetes, weight gain, gastritis, myopathy, cataracts, etc. You can't go on using the shotgun forever. So you need something more targeted, like a rifle. Only I'm calling this rifle azathioprine, or cyclosporin, or mycophenolate mofetil. Azathioprine works by inhibiting purine synthesis in rapidly dividing cells, like B and T cells. Cyclosporin inhibits the release of IL-2 and it impairs T cell activation. And mycophenolate works by inhibiting nucleotide synthesis, which also slows T and B cell replication. Now that's all well and good, but when choosing which of these steroid-sparing drugs to use in a patient with myasthenia, I usually consider what are the contraindications to therapy. For instance, a patient with chronic liver disease should not get azathioprine. It can cause hepatotoxicity, and this only makes pre-existing liver disease worse. We also check TPMT, or thiopurine methyltransferase, activity before starting azathioprine, because azathioprine is associated with a dose and duration-dependent hematologic toxicity. TPMT is one of the enzymes involved in the metabolism of azathioprine, so a defect in this pathway will increase the active metabolite 6-mercaptopurine in the blood, causing the hematologic toxicity and resultant myelosuppression. You don't always have to check the activity of this enzyme, but experts generally recommend checking it at least in patients with leukopenia. And leukopenia is bad for both azathioprine for this reason, and it's also bad for patients who want to start on mycophenolate, so you might go with cyclosporin here. Renal disease, on the other hand, is a contraindication to cyclosporin, so that takes you back to mycophenolate or azathioprine again. And compared to steroids, which take effect after a few weeks, these immunomodulators take months to years before patients really improve. Remember, these drugs are like a rifle being used by a sniper. To take out an army of disease will cost you quite a bit of time. And because we're comparing a rifle to a shotgun, it doesn't necessarily mean one's better than the other. According to a Cochrane review, azathioprine is just as effective as corticosteroids in treating myasthenia symptoms. We just like to use it in place of steroids because it's better tolerated in the long term. So what can you do as the provider to speed up the process while your patient's getting used to this long-acting medication? Well, as you probably know, there are acute and rapidly effective immunomodulating therapies you can use, which we often use for acute flares of myasthenia or for crises. These include plasmapheresis or intravenous immune globulin. Going along with a gun analogy, these therapies are like a raid, or an invasion, or a tactical nuclear strike or something. I don't know where they fit in the analogy chain, but it's getting pretty violent here. Needless to say, IVIG and plasmapheresis get in there quickly and they get the job done. As far as which one to choose between IVIG and plasmapheresis, the two are considered equivalent interventions, just like they are when you treat Guillain-Barré syndrome. You should also check out that episode if you haven't already, episode number 30, on how these different immunomodulatory therapies work. For the sake of time, we'll just skip over them for now. But let's say you're a pacifist. You hate this whole NRA analogy I've been building up. You've surrendered all arms, but you're not waving a white flag yet. What do? Well, it turns out thymectomy works extremely well in patients with thymoma. But why thymectomy? Here's what we know. The majority of patients with acetylcholine receptor antibody positive myasthenia gravis have thymic abnormalities, hyperplasia in 60 to 70%, and thymoma in 10 to 12%. Furthermore, since we've been attempting thymectomies for myasthenia for at least the last 75 years or so, the neurologic manifestations of disease often improve or disappear after surgical resection. The thymus contains a small number of myoid or muscle-like cells. These cells express acetylcholine receptors on their surface just like your muscle cells do, and they're the only known cells in the human body to express this intact acetylcholine receptor outside of muscle. It's thought that these ACH receptor expressing myoid cells may prime the helper T cells so that these eventually attack the ACH receptor and create infiltrating germinal centers in the hyperplastic thymus. Once the germinal centers are created, plasma cells divide and conquer, and as unique antigen-recognizing domains of antibodies are expressed, a subpopulation of B cells eventually produce antibodies to recognize the intact muscle ACH receptor. So all the machinery is there, and once the myoid cell membranes, like the acetylcholine receptor, are recognized by T cells, it's only time before the B cells begin to realize this can be a target of antibody production. In patients with thymoma, regardless of the symptoms of myasthenia, thymectomy is indicated as long as the patient is an appropriate surgical candidate and so long as resection is feasible. So refer the patient to CT surgery. In patients with thymomas who are not good surgical candidates, either due to infiltration of disease or comorbidities that increase perioperative surgical risk, then radiation and chemotherapy is going to be your best bet. But the next most pressing question is, should patients without thymoma be referred for thymectomy? Well, I don't think we really knew this answer until last summer, 2016. Multiple older, smaller, retrospective cohorts demonstrated slightly higher rates of remission among patients who underwent thymectomy for non-thymomatous myasthenia. The first of these studies was published more than 75 years ago. But several other studies showed no clinical improvements in thymectomy, or that thymectomy was no different than the medical management in the long term. Finally, in a 2016 systematic review that had identified 22 of these observational studies of patients with non-thymomatous myasthenia gravis, those who underwent thymectomy were more than twice as likely to achieve remission than if they had been treated with conservative medical management alone. And these results were strongly statistically significant. But they paled in comparison to the international randomized controlled MGTX trial published in the summer of that same year. What the MGTX investigators found was incredible. For patients with acetylcholine receptor antibody-associated myasthenia, thymectomy in patients without a thymoma improved outcomes across the board at 3-year follow-up. Functional outcome, check. Compared to the medical arm, which received prednisone monotherapy, thymectomy was associated with a lower quantitative myasthenia gravis score. Corticosteroid exposure reduction? Check. Thymectomy reduced the dose of prednisone necessary to achieve symptomatic remission. Requirement for additional immunomodulating therapy? Check. Hospitalizations? Check. Psychiatric disease related to medical illness? Check, check, check. Each of these outcome measures improved with thymectomy compared to prednisone alone. But all these great things being said, I would caution your interpretation of the findings. Like nearly any successful clinical trial, strict inclusion criteria were mandated in order to homogenize the population. Patients had to have myasthenia gravis for less than 3 years, they had to be 18 to 60 years of age, and they had to have an elevated acetylcholine receptor antibody level. Patients with only ocular myasthenia were excluded. I should also mention here that the benefit of thymectomy is not immediate, as the results of the MGTX trial have proven. The investigators evaluated 3-year clinical outcome measures. The 1-year remission rate is less than 20% according to pooled data from older clinical trials, which is still okay, but over 7 to 10 years, the remission rate increases up to 50% with thymectomy. In conclusion, and to summarize the data, thymectomy is generally recommended by most centers for patients with myasthenia gravis as long as the following criteria are met. First, patients must have generalized symptoms. Ocular symptoms don't count yet. Second, patients must have ACH receptor antibodies. no MuSK or LRP4 or calcium channel antibodies, which we see in the Lambert-Eaton syndrome. And third, and this is probably a soft call here, the patients must be younger than 60, which really just means they should be good, healthy surgical candidates. Unanswered questions regarding thymectomy include the appropriate age for surgery, when it should be performed in the course of the disease, but earlier is probably better as long as the symptoms are significant enough. Another question is the surgical approach, meaning transthoracic or transaxillary. And lastly, the role of thymectomy in patients with seronegative myasthenia, MuSK antibody-associated myasthenia, LRP4 disease, or patients with purely ocular disease who are seronegative. So there's a lot to follow up on here, and the studies are ongoing. In sum, there are 4 main tactics for treating myasthenia. First, symptomatic management with cholinesterase inhibitors like prurostigmine. These increase the available acetylcholine at the neuromuscular junction, but the treatment can be limited by its muscarinic side effects. Second, immunosuppression with steroids, then steroid-sparing agents, which are limited by the long-term toxicities. They take months usually to kick in, unlike prurostigmine, which can take minutes, but they provide good long-term control of the disease. Third, the acute management of flares, usually with IV immune globulin or plasmapheresis, which works over days to weeks, but has a limited lasting effect. And finally, thymectomy, which is indicated in patients with and without thymoma, as long as the patient has generalized myasthenia, acetylcholine receptor antibodies, and as long as they're a good surgical candidate. Alright, I think that's enough for this week. I'm Jim Siegler for Brainwaves. We'll see you next time.
Thanks for listening to Brainwaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Lee Rosevere. I'm Erica Mejia. Join us next time for another edition of Brainwaves.